Good evening, everyone, and welcome to our podcast this evening, titled Tears, Fears and Vaccine Engineers, the Jewish Community and Coronavirus. My name is Marie van der Zil, and I am the President of the Board of Deputies of British Jews, the representative body for the UK Jewish community. For 260 years, the Board of Deputies has worked with synagogues and other communal organisations from across the country to provide support and to represent their needs and interests for the betterment of British Jewry. During the global pandemic, the Jewish community has faced some unique challenges, and we are very sad to report at the moment that some 828 members of the Jewish community have died from COVID. Each one of these deaths is a tragic loss. When the first lockdown was introduced, we worked with the government, the opposition, and the Muslim community to amend emergency legislation to ensure that people would not be cremated against their preferences and that the religious freedoms of those who have died have been protected. We continue to work with our international partners, government, local councils, and with synagogues and communal organisations across the country to ensure that our community, alongside the rest of the country, stays safe. We are delighted to be joined by people from around the country this evening. If you can, please write in the comments section of the video where you are from so that we know where you are watching. I would now like to hand over to our Chief Executive, Gillian Meron, who will be chairing this evening's panel. Thank you.
Thank you very much, Marie, for that introduction. My name's Gillian Meron, and I'm the Chief Executive of the Board of Deputies of British Jews. And this evening, we are very proud to have brought together leading experts to reflect on the unique challenges that this pandemic has created for our community and to give us an update of where we are at. So with this in mind, it is my real honour to introduce our panellists. Dr. Charlotte Benjamin, North Central London Clinical Lead for the COVID vaccine. Professor David Katz, Executive Chair of the Jewish Medical Association and Medical Advisor to the Board of Deputies. Dr. Daniel Staetsky, Director of the European Jewish Demography Unit at Jewish Policy Research, and Moishe Sinitsky from the Jewish Burial Society in Manchester, Chevra, Kadisha. So, how will we be running this? Each panellist will make a brief introduction outlining their work prior to COVID and how it has changed throughout the pandemic. I'll then ask a follow-up question before opening up to ask the panellists questions that you submit from the audience. So if you've got a question you'd like to put to the panel, please write it in the comments section of the live stream. So let's come to our panellists. First of all, Dr. Charlotte Benjamin, you're very welcome. Perhaps you'd like to make some opening remarks.
Hi, thank you very much, Gillian, and thank you to the Board of Deputies for this really interesting sounding webinar we've got on tonight. So my name's Charlotte, and I live in Hendon. I'm a frum mother of 4, and I'm a GP. I do that part-time, and the rest of my week I do commissioning. I'm the Vice Chair of North Central London CCG. That's the area that buys health services for Barnet, Enfield, Haringey, Camden and Islington. And I'm the clinical lead for vaccines across this area. I kind of think, what did I do before the COVID vaccination programme? Because sort of every waking moment seems to be taken up with the vaccine at the moment, the mobilisation, the questions, and trying to help ensure it runs smoothly. But prior to this, so 2 days a week, I'm a GP, and we see a lot of COVID in general practice. My practice has 12,000 patients, and we were staggered by the amount of losses we had in March, April, May last year. We lost a huge proportion of our elderly population and some not so elderly, patients who'd been known for decades to our practice, and that was a tremendous loss, obviously, for their families, but also we felt it as well. So the impact of COVID, also the impact on people who weren't suffering from COVID, who found that NHS services and health services really were shut down, and we changed overnight what we did. So instead of just walking into your GP surgery, we'd be doing it by telephone, and some people really like that and some people find it more difficult. But actually things have changed, and there's a lot of good that's happened as well as some difficulties as well. So in addition to the GP work, in terms of the commissioning, we had to completely redesign health services to enable the hospitals to cope with COVID. So as more and more work was being done with supporting critical care and people who are significantly unwell in the hospitals, we had to make sure that as soon as they were ready to leave, they had somewhere to go, that we worked with local authorities, worked with community services to have step-down beds and facilities, and general practice helped to do some of that to depressurize some of the hospital work, trying to keep patients in the community and prevent people going to hospital where appropriate, and also helping step people down. And in terms of doing that in the first wave and the second wave, as a system, we have coped. So the worry that you will have heard the politicians and in the news, people saying that the NHS were worried it won't cope. Thankfully, we have coped, and it's not one bit of the system, it's the whole bit of the system working together collaboratively. And it has been very difficult and everybody is tired, but actually we're working differently as a system and taking that forward as we go out of the COVID pandemic and as we move to some sort of normality in the future. There are huge lessons learned, and healthcare for people, for residents of across the country is much better with collaboration rather than having sort of separate siloed working. So life has changed in terms of my role and my work, both parts of my work because of COVID. But I'm really thrilled to be involved with the COVID vaccine, and that's the huge part of the solution. So really pleased, and we're doing well. We're aiming to get virtually all of our residents who are over 70 who want the vaccine vaccinated by middle of February, and we're on target for that. So that's tremendously exciting that we're able to vaccinate the most vulnerable in our population.
Thank you very much, Charlotte. Let me turn now to Professor David Katz. Over to you, and welcome.
Good evening, and thank you for asking me to take part in this. First of all, my background is in a different slant of medicine. My background is in the laboratory. I haven't been involved with patient care for many, many years. And therefore, I have some experience in immunopathology of the issues that are important in COVID. I had some experience of looking at responses to viruses, how they work, how the immune system is triggered and initiated. And some people like Charlotte might remember that I actually had to try and educate them about some of these complicated issues earlier in their lives. Now, in turning to the other aspect of my title, Jewish Medical Association, for some years, we've tried to coordinate and have a kind of central clearinghouse, if you like, for Jewish doctors in the UK. Our remit is educating Jewish doctors about Jewish aspects of medical practice, and educating and helping Jewish doctors to educate the wider public about Jewish aspects, and including in that about links with Israel, with Israeli doctors and Israeli medicine, and maybe we're going to come back to that a little later. Now, with regard to what's happened now, one of my other roles has been to look at documents, to advise on documents, to advise on ethics, and to review proposals for new kinds of work or new kinds of equipment that have emerged. And of course, one of the triumphs of the whole COVID episode has been the remarkable biomedical scientific advances that have been made as part of the process. And I think that's one point that's often forgotten, how remarkable this has been. If you look back to polio, it took from 1930s March of Dimes to 1950s to get a vaccine. Here we've got a disease that started at the beginning of this 2020 probably, and we're already at the vaccine stage so rapidly. So I'm in my role within the British Medical Association, I've been involved in that kind of explanation activity. And finally, within the Jewish community, there have been lots of things that have had to, that support has been needed. Support has been needed for circumcision to continue. Support has been needed for burial societies who've had a terribly difficult time. Support has been needed for promoting the fact that Jewish identity within the context of both patients and, of course, in the context of the doctors. And that's just one other aspect. At the beginning, the Jewish Medical Association helped to provide meals for healthcare workers who are on the front line. And of course, Jewish doctors and Jewish healthcare professionals are very active with their colleagues in working on this particular disease.
Thank you very much for that introduction, David. So, Dr. Daniel Staetsky, welcome to the panel.
Thank you, Gillian. I will present, first of all, I will say a few words about JPR. We are a research body. Our mission is to collect and analyze statistics that concern the condition of Jews, and not only we collect and analyze, we also disseminate it, and not only statistics, but also what's called evidence-based insights. And we do it mostly, not exclusively, we're driven by desire to support policy development. So in that sense, we do what it says on the tin. We support both Jewish and non-Jewish organizations in our work. And our particular focus is on Jews in the United Kingdom and also in Europe, although from time to time we have an international, truly global aspect to our research. It's worth saying here, and really parenthetically, that JPR is quite an old institution. It goes back all the way to the 40s, really. It was established on the American soil, then in the 60s it moved to Europe. And since then, pretty consistently, demography and statistics are core features of our program. Today, we have several research strands along these lines, and Dr. Jonathan Boyd is the executive director of the institute. It's only natural for an institution of that kind to evolve significantly in response to societal transformation. And no doubt, coronavirus crisis is a significant societal transformation. Social priorities change, interests change, and our aim, our mission was to respond to this change and inform more on the society on the issue of Jews and coronavirus. We put an entire novel research program that could be entitled, indeed, Jews and Coronavirus. Now, when I use words such as societal transformation, it sounds a little abstract. It is genuine transformation in interests of public and policymakers. So in the last year, we have been closely looking at the questions such as, how are Jews being affected by pandemic? Do they die more or less? Why does this happen? And above all, is there any special about Jewish population that we need to know in the context of the coronavirus pandemic? And then, metaphorically, moving from the dead to the living, how does the pandemic affect Jewish communities socially, politically, economically? For those who continue to live, how life is to be restored. Within this broad program, we established two separate strands of research, I should say. The first addresses the issues of Jewish mortality. So as I said, do Jews die more or less than others, and why that is happening? In this research, we metaphorically, of course, traveled far and wide. We contacted globally Jewish burial societies. We collected data from them, both on the volume of deaths during the pandemic, but also pre-pandemic, to draw this kind of comparison. This project was basically carried out in a collaboration with an expert from the Statistical Bureau of the State of Israel. And it was carried out in the European Jewish Demography Unit, which is a special unit here. The second strand of research focused on the economic effects of the pandemic among Jews. And in this strand, we created a completely innovative product that is an online survey panel. This panel, in simplicity, is a very large sample of Jewish people in the UK who we recruited according to the best practice in this area. And we recruited them in order to ask them questions from time to time, periodically, on a wide range of issues, coronavirus pandemic included. So far, we conducted one survey on that particular panel, and we managed to map very comprehensively both epidemiology and sociology of coronavirus pandemic in the UK. Matters such as the scope of exposure to COVID, losses of life, changes to family arrangements, changes to people's finances have been very decisively documented. We expect these findings to be of great interest to Jewish charities in particular, for better understanding of their target audiences and of their donor base. And if I have to sum up, perhaps there's a strong line of continuity in our work, in the sense that we continue to build a body of knowledge. We continue to build it when we stick to the same principles and methodology, but our topic is different. Our theme now is how Jews fare under the coronavirus pandemic.
Thank you very much for that, Daniel. And let's now turn, last but absolutely not least, Moishe Sinitsky. You're very welcome on tonight's panel.
Thank you. Good evening. Thanks for having me. My role in the community here in Manchester is I'm involved in the Jewish burial societies and the Chevra Kadishas and helping out when someone suffers a bereavement. Before the pandemic, it was quite simple. Most people, when they suffer bereavement, would receive the medical certificate from their own doctor or from a hospital. I would only get involved when a death gets referred to the coroner, or if there's some other complications. Otherwise, it was quite simple. You'd get a death certificate, you take it to the registrars, you'd get your green slip of paper, you take it to your undertakers, to Goldfinds or whoever, and then off with the burial. Beginning of March last year, a number of us were called in to GMP headquarters in Manchester, where we were addressed by one of the sea coroners in Manchester to actually warn us of the upcoming pandemic with frightening numbers she told us would happen, the amount of dead and so on and so forth, and to get us ready. It was quite frightening to hear what she had to say. She was telling us to get body bags ready and do we have enough fridge space and so on and so forth. We explained to her that, you know, we like to bury as soon as possible and we wouldn't really be a burden on any mortuaries' fridges as long as they would provide paperwork, you know, ASAP. Comes towards the end of March, and just out of the blue, it just hit us from one Thursday evening. The phone started ringing from a couple of families. 2 people passed away with COVID. Registrars were closed. Everything had to be done by email. Hospitals were closed. You couldn't get in. Families weren't allowed in. So I quickly made contacts with all the hospitals, all the bereavement offices, all the registrars. Many registrars gave me their personal mobile numbers. And thankfully, I got a system going whereby I was able to get deaths registered 1, 2, 3, you know, sometimes 5, 6, 7 in a day. Even over Passover, even over Pesach, people were dying on Yom Tov. I was getting calls. We even did a burial on Yom Tov itself, second day Yom Tov, which was Easter Friday. The registrars were open for us. The hospital bereavements were open. Easter Sunday, we had close to 10 deaths. And we were taking bodies out of the mortuaries. People were knocking on my door at all hours of the night, frightened of this. What Marie mentioned earlier, there's the frightening thought of cremation, which somehow came about. But thankfully, you know, everything worked well. We opened up very good connections with registrars and hospitals, and there were no delays anywhere in deaths, and that's how we went along, and that's where we're still standing.
Thank you very much for that, Moishe. And I'm sure, like me, the audience will have been really very taken by what our panel have said about how life has changed. We know that life's changed for all of us, but it's really fascinating to hear how it has changed for all of you. And a thanks from all of us for the work that you've all been doing, one way or another, to support our community through this difficult time. And we're hearing a lot about the pressures that you're under as well. So with that, now that we have a sense of who you all are and the work that you do, I'm now going to come to you to ask a specific question. And I'm going to start with Professor David Katz. So David, you referred to this. So let's hear a bit more about the work of the Jewish Medical Association. Part of your work, of course, in the association is to promote links between Israeli and British medicine. So can you tell us a bit about what the UK should learn from Israel's response to the pandemic, and what the UK should be learning from Israel? So in other words, what should we all be learning from each other, UK to Israel and back again?
Well, one of the obvious things which we just always have to bear in mind is that viruses are no respecters of national boundaries, and they're much less respecters of national boundaries the more we have international travel and people migrating from one place to another. And, it's interesting that as of today, it's the so-called British virus that's causing some problems in Israel, and it's the South African virus that's causing some problems in the UK. They're all variants and strains of the same virus. That's number one. Number two, with regard to what we've taken in the UK, just to say that, of course, individual contact between Jewish doctors, between non-Jewish doctors, the entire British medicine and Israel, is, of course, they're learning all the time. One just wonders, I don't know for certain, but for example, the remarkable trials done in Britain on drugs that help in the acute phase, one leading to the introduction of dexamethasone, of a steroid, is the kind of thing that has been picked up by our Israeli colleagues, and vice versa. And we hear reports about these new wonder drugs all the time. One has to remember that reports about new wonder drugs may be good news for the press, but always these need validation, testing, trialing, and to prove that they really are worth investing patient lives in them. And of course, we all know about bleach, but we also know the example that I gave, dexamethasone, that was tested and under the most rigorous kind of standards in the UK. Now, on the other hand, we've also changed what we do as an association. We're running as often as we can webinars, seminars, and Israelis have contributed as part of that. And that's part of the mutual understanding, informing people what's happening in either country. The really huge issue at this moment, however, is what Britain can learn and what the world can learn from what's happening in Israel with regard to immunization. And it's some very important lessons which the world can learn, but Britain can learn too. One of them is that the background in Israel includes a background of a country that's of a manageable size, but it's about the same size in population as London, manageable size to a certain extent, but that it's a society that's actually quite closely knit and has a lot of common features amongst it. But at the same time, it has disparate cultures and health inequalities within it. And recognizing that and recognizing the weaknesses and strength of society is something that Israel has clearly taken on board in relation to this. But there are also healthcare system issues that have been operating there. The nature of the sick funds, founded in the years of the foundation of the state as a kind of classic socialist service to the workers, these sick funds are integrated into the very fabric of Israeli society. They're the 4 sick funds, and the way they are funded and the way they're organized has been one of the strengths. The way that data within them is collected, integrated into IT systems automatically at any one moment in time. In Israel, you know about childhood immunizations. You know how the childhood immunizations have gone, and you know how many children have had this. And this applies, incidentally, like throughout the Israeli population. And actually, the IT services in relationship to childhood immunization in the States are available in the Palestinian Authority area as well. And it's not generally known, but of course, that part of the world, as well, in view of poliovirus epidemics in the not so distant past, that part of the world has absolutely one of the highest rates of polio immunization anywhere. So that's the second issue. The third issue is to grasp the importance of the immunization. And of course, there is this anti-vaccination lobby, and maybe we're going to come back to that, but the importance of the immunization is recognized by society as a whole. And I think that is the lesson that we can all take away from this pandemic, which has been really highlighted in the Israeli example.
Thank you very much, David. And of course, you're right that this is no respecter of borders, as we find. Let me come down to Moishe. Moishe, I know that the work you do to ensure the smooth running of the Manchester Burial Society is greatly appreciated. Could you tell us a bit more about some of the challenges you've had to overcome during the pandemic to ensure this smooth running that you do so well?
Well, at the beginning of the pandemic, it was pretty frightening. End of March, beginning of April, everyone was in lockdown. There was no one around. I'm just one of a very large team of volunteers, a group of Misaskim who in Manchester who will, most of us have our own jobs, but we'll just drop anything when it comes to someone passing away. But when we're getting calls in of people dying of COVID, none of us knew exactly what it was. It was right at the start, right at the beginning. Most of the mortuaries that we deal with in Manchester made us come to the mortuary with the coffin. They would put the body, which was already sealed in 2 body bags inside the bag, made us nail it down and take it. And they told us to take it straight to the burial ground, which of course is not something that we would do because we have to carry out the Tahara. And so that was one complication we had to overcome. Professor Katz was the guided most of the Chevra Kadishas around how to do Tahara. At the beginning, in the first few weeks, we actually took guidance from the Beth Din and actually just cutting the body bags open and just putting the tachrich and the shrouding on and leaving it like that. But as the weeks went by, it felt terrible just to not do Tahara on anyone, and we kitted ourselves out with a huge amount of PPE. We had a dedicated team of the men's, dedicated team of the ladies, and don't forget these ladies are just dropping everything, their kids, wherever it is at home, because we wouldn't allow any older ladies to do Tahara. They stayed at home, it's too vulnerable. So we had young team of ladies, young team of men, small groups who had to kit themselves out in full PPE, very, very uncomfortable, and carry out a Tahara in a certain way without any splashing, according to the way David Katz had told us to do it.
Moishe, can I just interrupt you? It would be good
Yeah.
for the audience if you just explained a bit more about what Tahara is.
Okay, the Tahara is the purification of the body, which basically just means once we bring a body out of hospital or from a home, wherever they passed away, they're washed down, water's poured over them, cleaned, and then they are dressed in white tachrich, in white shrouds. Everyone is exactly the same after they've died. I don't question anyone. Whenever I get a phone call from anyone, someone's passed away, I don't ask any questions, if they're religious, not religious, anyone like that. Everyone gets the same service. I chase up the authorities for paperwork as long as they want burial ASAP. I'm on it. And when you're dealing with water and splashing with someone who's passed away from COVID, there's a good chance that that will splash onto you. So that was one of the very difficult things to overcome. In addition to going into mortuaries, many people who died, I know for a fact, even though the local authorities used to publish numbers up in Manchester, so many people died in our area. A lot of them actually had passed away in hospitals and went in without COVID and caught it in hospitals. So we were already frightened just to go into the mortuaries because there seems to be COVID everywhere. So that was one of the main issues that we had to overcome. Secondly, I mean, for every family, every bereavement is tragic and everyone wants to have their funeral but the laws changed. We could only have 30 people at a funeral plus your burial societies. Sometimes it's very difficult for the families to even understand that. You know, many very well-known people passed away in Manchester since March. Some great rabbis, some very well-known family people, and instead of the usual way where we would put signs up in synagogues and send messages around, we just tried to keep it very quiet. You know, just not to have, and it was just the strangest of experiences, just taking people straight from the mortuary to a tahara, and then from there straight to the burial ground for a burial with, you know, the minimum of people around. Yes, there were many people watching, most of them on Zoom, which was a new concept, and having levayas, which was something that definitely helped families. And, you know, but sometimes word gets around and some other people do turn up for levayas because they just guessed where it would be. So that's just one of the difficulties, you know, and that's still ongoing. You can still only have a certain amount of people at a levaya. You know, with the authorities, thankfully, I was able to build up tremendous connections with all, as I said earlier, with all the registrars, with all the hospitals, with the coroners especially. And, you know, even today I was busy. There were 2 deaths here in Manchester, which, you know, I had to chase hospitals for a couple of hours, but thankfully they were both buried in the end before nightfall. There are times where there is no cause of death and we're still able to do scanning, even though during the pandemic, rather than have a regular post-mortem, most coroners, or all the coroners, allow us to do scanning to give a cause of death. So there's quite a lot of, you know, going on, because that's, again, going into hospitals for the scan, and the people going in are frightened of catching COVID. There's been many deaths at home where there was suspected COVID with the person or any other family member. Again, you've got to dress up in full PPE to be able to take the body out of the house. Again, very uncomfortable, but we've got through it, and thankfully I don't think anyone who's on any of the burial teams actually caught COVID from doing this great mitzvah. So we are where we are, and thankfully, you know, we've got great help from the authorities up here in Manchester, as I'm sure it is in London also and elsewhere.
Well, you certainly built the relationships to make that possible, and I'm sure everybody listening was very touched when you talked about how you and your teams have felt in this time, because clearly it is very affecting emotionally as well as practically. So thank you for explaining that to
Can I
us.
just say one more thing? Sorry,
Please do. You're very welcome. Yeah.
Most of our team, thankfully, have all had the first vaccination.
Good.
Which is quite a comfort.
I'm sure it is, and we will come on to more about vaccination too. So let me come now to Daniel. JPR have produced a number of key publications during the pandemic. Can you give us a few of those key findings from some of those publications? It would be interesting to hear about them.
Thank you. Yes, as I mentioned at the beginning, we established 2 research strands in response to the pandemic, the epidemiological ones, it's about mortality, and the socioeconomic one, and I will present a few highlights here in the time that I have. I must say that we published in total about 7 publications. They're all available on the JPR website. They can be downloaded from there for free, and I would encourage people to do so. I will just touch on a few findings which I think are of particular importance today. So let me start with the epidemiological strand, and I will do so by mentioning actually a very significant scientific development that happened outside of the JPR, but that ought to be mentioned today. In the summer of 2020, the Office for National Statistics, which is of course the chief statistical institution in this country, published a remarkable paper, truly remarkable. Normally, that word is used as some sort of soft flattery. In this case, it's understatement. It created a revolution in British Jewish demography because it built on the unique resource. And that paper revealed that actually disproportionately high mortality from coronavirus. It was very unambiguous, given the quality of research. And not only that, Jews had disproportionately high mortality irrespective of socioeconomic status compared to their equals, irrespective of age, irrespective of place of residence. So our first task was dictated in a way by that paper. We had to clarify that finding, to explain it to ourselves, and before we could do it, to explain it to others. And there was a great deal to explain because the paper's findings flew in the face of about 100 years of research in Jewish demography. Those 100 years of research told us that Jews are long lifers. Their mortality is typically lower no matter where they live. That's true of Britain today, of Soviet Union that's now gone, of African countries, North African countries. Doesn't matter where you go, Jews are basically quite healthy population, and we should expect them to have lower mortality. That was not so. So in response to that publication, which appeared absurd at the first sight, we launched a reanalysis and investigation, and we clarified that this particular situation was unique to COVID, i.e. that with respect to all other causes of death, causes of illness, Jewish mortality in Britain was indeed low. It was lower than among other groups, no matter which group. And it is COVID that creates that particular situation. We still do not know why, but we went as far. We have now some hypotheses, we eliminated others. We also revealed something extraordinarily important, and that is that that particular finding of high mortality from COVID had nothing to do with strictly Orthodox community, nothing at all. And I want to be very clear here. What I'm not saying is that nothing unusual happened there. They certainly had deaths from coronavirus. More than mortality was elevated as well. But the basic finding of elevated mortality among Jews in Britain was not because of the strictly Orthodox. It was distinctly mainstream Jewish phenomenon. And I must say also parenthetically that strictly Orthodox deaths, the community has about 100 deaths per year, something like this, whilst the entire Jewish British community has about 2,500 deaths per year. So purely numerically, strictly Orthodox don't exercise that power to shape the picture of death. These are the epidemiological findings, and now I'm moving on to the socioeconomic strand. And here, really, the most important insight probably relates to people's prosperity and financial security. That's the second thing that in everyone's mind after the epidemiological picture. As I mentioned, we launched a very large survey of Jewish British population 5-6 months into the pandemic. And in that survey, we asked very detailed questions about people's financial circumstances, both before the pandemic and into the pandemic. And we could document the extent of acute disadvantage, loss of income, and change in financial circumstances. And the overarching, I would say, combined impression from different questions that we asked is that there have been some changes to financial security in the British Jewish community, and yet there hasn't been a fundamental, profound transformation in this respect. A large majority of people report stability. Some people report changes, and these changes are to the better and to the worse. But these are margins. The core of the community is rather stable, and that applies not just to people's financial circumstances, but also to their capacity and willingness to give charitable donations, to pay synagogue membership fees, and such like. I must say that these findings are correspond very well with the national picture, in the sense that in the whole nation, there have been sound documentation of the existence of two groups that suffered some loss of income as a result of loss of jobs, for example, but also groups that accumulated savings because the economic activity was reduced. These are holidays not taken, these are commute not undertaken, and such like, and this is also present in Jewish community. So large stability by and large, and changes on the margins. This is, of course, 6 months into the pandemic, and JPR will be launching another survey in 1 to 2 months to create a more updated picture in this respect. So not much really left for me to say, apart from the fact that these findings have been presented far and wide to the leadership of the British Jewish community. They're being processed, they're being studied and comprehended as I speak. And this will continue to happen. So the pandemic is with us, unfortunately, and not unfortunately, our program is also in full gear. So you should expect to hear from us more on these and other issues before too long. Thank you.
Thank you very much for that, Daniel. And obviously the work that's done will inform us as a community and I hope strengthen us. And so now I'd like to come to Charlotte with a question for you. And before I do, just to remind our audience, please feel free to submit your questions to the panel because I'll be coming to those questions next. But as a starter, Charlotte, there's understandably been a lot of reports and ever developing news with regard to the vaccines. What are the key misconceptions people have in your experience about receiving the vaccine?
Thank you. So with the vaccine overall, there's a lot of excitement. Most people are desperate to get the vaccine. And as I became quickly aware, until the last person who wants the vaccine gets it, there'll be people who are not happy. So we're trying to get the vaccine and rolling out the programme nationally, and indeed the rest of the world as well, as quickly as we can. So most people do want the vaccine. But there are people who don't want the vaccine at the moment. And we call that, at the moment, we sort of call that vaccine hesitancy. And that's a spectrum ranging from people who on the one hand are not quite sure and just need a very little amount of prompting, be it from a receptionist in a GP practice speaking to them, be it a nurse or a GP, or be it someone from their community speaking to them. Then the other end of that are anti-vaxxers, and there are groups of people who vehemently disagree with vaccination as a whole, and some people who don't agree with it for coronavirus, and there are some political groups who are also anti-vaxxers. They're in the small minority in terms of what we're seeing. The majority of people we're seeing are in that vaccine hesitancy, who are more the other end of the spectrum, who they're not sure. And one of the main things that they ask is, how come it's been done so quickly? So Professor Katz alluded to the length of time, the decades that it took to get the polio virus, the vaccine established, and that was decades ago. But actually people say, normally it takes about 10 to 15 years to get a vaccine established. How have you been able to do it within a year? And that is miraculous. And the main reason is that there are different stages to the vaccine, ranging from sort of pre-exploratory phases and preclinical trials, clinical trials, and there are 3 parts to those. Then there's approval of a vaccine. Then there's post marketing surveillance being done. So there are lots of different phases, and it costs absolutely millions or billions to actually produce vaccines. So normally each stage is done, and then it's assessed and to see, is there more funding for it? And the funding is the big challenge, and that's what takes the time. But because of this unprecedented demand for a vaccine, because of the pandemic we ended up being in, there's an enormous amount of collaboration worldwide. So scientific collaboration worldwide, financial collaboration to enable the steps of the vaccine program to be done actually at the same time. So instead of doing one bit, assessing it, do we fund it, moving on to the next bit. But the arms of the parts of the vaccine trial didn't actually change. And the crucial bit of the safety arm was no shorter than it would be in trials for any other medical product. We're really fortunate that in the UK, our licensing body for medicines is the MHRA, the Medicines and Healthcare Regulatory Agency. And that has some of the toughest standards across the world and is very well respected. And this is an independent body, it's independent from the government. And this scrutinised over weeks to months the data that came out from the scientific research around the vaccines. And they said in December time, first of all, it was Pfizer, and then it was AstraZeneca, and they were given temporary license to start vaccinating in this pandemic. So the speed of it is well understood because of huge collaboration and because of the putting the different parts of the vaccine process actually in parallel together to enable it to happen instead of in 10 to 15 years, it's happened within a year. And the other thing to say is that a lot of this work didn't start afresh. So the work in Oxford, there'd been work being done on coronavirus vaccines prior to COVID-19, and certainly the work also with mRNA. That's a much newer type of vaccine. That's the Pfizer vaccine. This didn't start afresh come January, when we became aware of the coronavirus vaccine. So that's one of the main questions. There are lots of other questions that people have, ranging from the bizarre about, are there microchips in it, which clearly there are no microchips in a vaccine that's being promoted. Will it affect my fertility? And certainly there is absolutely no evidence that the coronavirus vaccine affects fertility. But indeed, if you get coronavirus itself, if you get it badly, males, it can cause an inflammation of the testes, which can affect your fertility. Also, if you've been unwell, that in itself cannot be good for your fertility. So COVID itself is not probably great for your fertility, but there is no evidence at all that coronavirus vaccine affects fertility. And indeed, the Royal College of Obstetricians and Gynecologists have very clearly stated that as well. The majority of the anxieties people have are also because it feels new. So the trials on the first vaccine that came out, you'll know, is the Pfizer vaccine, and that had 44,000 people that took part in the vaccine, half getting a placebo and half getting the vaccine. So that was tens of thousands of people receiving the vaccine. But since then, we've got millions of people in Britain who've had it, and I forget the actual figure this weekend. I think it's over 10 million this weekend now that have had it. So that's a large body of people who've actually had the vaccine, which is very, very reassuring. People worry about side effects, and there's nothing in life that doesn't have side effects. With vaccines, the commonest side effects people get are very short-lived, within hours to days of it. And we do see people get a sore arm. I had the vaccine done end of December, and I had a sore arm for a couple of days. People can get a mild fever. And that's often the body mounting an immune response to it. So I say often that's something positively to look at. And we recommend just simple paracetamol if people get side effects. In terms of long-term side effects, now nobody can give an answer to will there be any long-term side effects in 10 or 20 years' time, because clearly these haven't been around for that long. What we do have is a lot of data on other vaccines, and we know that vaccines have revolutionised healthcare and revolutionised the health of our population. And we know that the likelihood is that these vaccines are not likely to show long-term side effects. But what we do know is COVID and getting COVID, and there still is a lot of COVID around, if you get it, you are likely to have problems from it. And the statistics for people who are over 70, between 70 and 84, is up to 5% mortality, and with a new variant can be 6% mortality. That's huge. That's risky. That's much riskier than going in a plane. That's much riskier than doing thousands of different car journeys. And they say that if you get COVID and you're over 70, that's more risky than climbing Mount Everest. Now, most 70-year-olds I know, including my own parents, would probably think very hard about going to climb Mount Everest because it would seem full of risk. But actually getting COVID is a riskier proposition. So can we guarantee that there's absolutely no long-term side effects with the vaccine? That isn't something anyone can say. But what we know is it is safe. It's likely to carry on being safe. There's a lot of analysis since the vaccine's been done to actually check there's a system to report any side effects. And thus far, we've seen very, very, very few side effects, which is great. So what we know is this hopefully is a significant part of the solution for being able to get back to normal. And this is something that's safe and that we have the absolute confidence. One other thing I'd say is that we know that people from different ethnic communities, the BAME, the Black and Ethnic Minority community, are less likely to take up the vaccine. There is more vaccine hesitancy. And we're doing a lot of work to encourage, because we know that they have higher mortality rates, higher rates of death from getting COVID. So we're doing a lot of different work to actually try to encourage communities. And I've done a lot of webinars with social care staff from care homes. And actually, when you talk to people, they want reassurance from people. They want reassurance and correct information being given to them, the ability to ask questions. Respectful dialogue is incredibly important. People do not want to feel that they're being pressurized into this. But actually what counts almost more than anything else is somebody they know from their own community having the vaccine. So really promoting amongst people who are leaders, people who are famous within the BAME communities can actually do an awful lot of good to help promote it. And I'm saying to all the vaccinated in North Central London, every time you vaccinate someone, when they say thank you, say to them afterwards, please go and promote it to your friends, to your family, to your community, because that's what's going to make a difference. And the more people that have it, the more we can approach this so-called herd immunity, which is people having it so that that can really help the levels of COVID really drop down. The more that's really dependent on the number of people that take up the vaccine. So the more we can encourage people around us, our friends, our family, our community, our colleagues, the better that is. Thanks.
Thanks, Charlotte. It's true, those who are vaccinated are the best ambassadors for vaccination. So I hope people do take heed of what you say. So I'm now going to say to the panel, we've got a number of questions coming in, which is great. And thank you to our audience for sending them in. The first one that I'm going to turn to is this one. In terms of the Jewish community, what do you think are going to be the long-term impacts of the pandemic? And that could be any long-term impacts, of course. So I'm going to come first to David and then see if Charlotte might like to comment on that in view of her earlier comments. So David.
Well, depends on whether you think whether you want to know about the long-term impact on the Jewish community or on the Jewish community as part of wider society. I think on the Jewish community itself, we've already seen that in the situation of risk, the Jewish community has responded, and as a whole, the Jewish community has recognized that the risk to life and the need for better healthcare, the need for avoiding infection is important. There are pockets where that hasn't applied, but those pockets, fortunately, are not necessarily the dominant one. With regard to the Jewish community also, the recognition about immunization, the importance of immunization, goes right back to the history of immunization in the 18th century. And it's great that this has been recognized within the community. But the wider changes also is in the recognition how much we're part of society. Inequalities within our communities, economic inequalities, educational inequalities, affect our communities in the same way as they affect the rest of society. And one of the big contributions to this field is by a British Jew, Sir Michael Marmot, who's pointed out that COVID-19 has just amplified the importance that we must work all towards avoiding those kinds of inequalities. And it's an important point. The other issue, of course, is the way we gather, the way we collect, the way we educate our children. We do this in the context of communities, and the information technology has had its impact. We don't know whether we're going to go back to having ordinary funerals or Zoom funerals in the future. We don't know whether we're going to get communal get-togethers on the internet, which wouldn't have happened 2 years ago. We don't know whether education is going to be done in a different kind of way. But the one thing is that we are a fortunate community in that we live in parts of the world which really are quite sophisticated. And hopefully we're going to be able to take advantage of that to improve the way our community operates, rather than to have it possibly relapse into some bad habits that have arisen in the past.
Thanks very much, David. Charlotte, can you add anything about what you think and about the long-term impacts of the pandemic? And I'm actually quite interested if there's anything perhaps in particular with your patients or your direct experience you might feel you want to comment on.
Thanks, Gillian. So I think there's the loss. So there's loss of relatives and friends from people who have sadly died from COVID. Then there's the effects for people who've survived COVID. And we see this concept of something called long COVID, which is a new illness, which obviously we hadn't seen before, which can affect sort of almost any organ of the body. And we're learning more and more about that. And we're beginning in London just over the next few weeks to set up clinics called long COVID clinics, which will be, I referenced earlier on about collaboration of different parts of the health system working together. These will be multidisciplinary team clinics with hospital staff, general practice staff, community and local authority staff as well, really trying to support, because different people have very different needs. And you'd have seen on the news people reference who have something called brain fog, where they feel that they're very much more forgetful than they have been previously. They have less focus than previously. People who have ongoing sort of palpitations where they're very aware of their heart beating, fatigue, all sorts of very, very wide-ranging symptoms. So I think the challenge for society in general and for the Jewish community is how do we stay safe to protect ourselves from dying from COVID? And that, obviously, the vaccine is one strong important arm to that. The other is carrying on with the very important public health messages of distancing, wearing masks, washing our hands. That still needs to be done at the moment. But then I think where we're really fortunate with the community, and so I work in Hendon, so a third of our patients are Jewish, and actually those are the consultations where actually I really feel the support behind the patient. So those who are struggling have a lot of support networks. So we have the formal networks, the statutory local authority networks. We have huge organisations like Jewish Care that support people, and they're doing it differently, obviously, because people can't go face to face to the different centres, but they're doing a lot on the telephone. But then you also have the informal Jewish network, often around shuls, often around communities. And that's absolutely fantastic. And the amount of voluntary work, I mean, I can see through my kids, the amount since COVID that, they've been involved doing voluntary work, but actually since COVID hit, they are doing so much more. And one of my daughters, A-levels finished, she could drive, she was going delivering prescriptions to people, taking food to people, much more than she would have done if there wasn't a pandemic. And I think that's really the strength of the community. Organisations like GIFT in certain areas have been fantastic, but I think where people feel very lonely and where people feel frightened, it's that sense of other people around them giving them support, and that's what the Jewish community does so very well. And I'm really proud of that, and it's a delight for the patients I speak to, and I feel that richness of community support around them is absolutely fantastic. And I think we'll see more of that, and that needs to continue, because the problems from COVID aren't going to go away overnight.
That's absolutely right. Let's hope we do continue to see the good and new creative ways of working, and the new and creative ways we've seen of supporting our community, that they may continue long into the future, whatever happens with COVID. Now, the question that a lot of people have asked, and we're now coming to this one, and I'll ask Daniel to speak on this one, is why did the Jewish community suffer so disproportionately in the first wave of the pandemic? So, Daniel, can you enlighten us?
Thank you. I think it's easy for me to start answering this by covering first what didn't happen, or what the factors that initially we suspected that they were responsible, but actually we eliminated them as time went on. Initially, when the first paper on this subject came out, and it came out from the Office for National Statistics, as I mentioned, before that happened, the suspicion, the strong suspicion was that it's just due to age. Perhaps Jewish community is slightly more aged, and that made its effect. Or perhaps it could be due to the fact that most Jews in Britain live in London, and London was one of the most affected geographies. So no wonder that these factors could have influenced the picture. However, that research made it clear that none of these factors were responsible, that there was something that we could call a Jewish factor. And this is, so we arrived to it by process of elimination, if you wish, in very convincing elimination. And when we faced that particular Jewish factor, we asked ourselves what it could be, relying on the previous literature in this area. And our hypothesis now is by no means a definitive answer, but it's a very strong hypothesis that it has something to do with greater Jewish sociability. And by sociability, I mean we come together as a community, perhaps more than others on average. This happens within the ritual context, within the context of synagogue and ritual life, but also outside of this context. A very sound evidence to that effect comes from surveys of social life of non-Jewish communities across Europe. There are multiple surveys, for example, that ask people, how often do you attend the place of worship? And people give certain answers, and I can tell you rather unambiguously that no matter where we look, which Jewish community in Europe we choose, the levels of attendance of a synagogue are higher than in a general society when it comes to church attendance. And by the way, that applies to strictly Orthodox, of course, to mainstream Orthodox, and to the what's called the progressive, to the Reform and liberal Jews. Across all these streams, the levels of synagogue attendance are higher than the church attendance in the general population. So these are very objective measures that can tell you we are more sociable. Perhaps I emphasize this had an effect on the British Jewish community. I also must say that Jews in Britain were particularly badly affected by coronavirus. But what we do know from our international research that it's by no means not a fate, in the sense that we documented a wide spectrum of situation across the Jewish world. The only community that we could see that is very similar to the British Jews is the Jewish community of Brussels in Belgium. That community was also very, very hardly affected. There's another one in Sweden, particularly in Stockholm. But there's a wide range of the situation. There are communities that were very lightly affected in the first wave, for example, German Jewish community. Jewish communities in Italy, some of them were affected, such as Milano, some of them almost not, such as Rome. So there's a wide spectrum of situations. All Jews are sociable, but not all Jews suffered equally, and perhaps there's some sort of impact of chance as well. So, whether the coronavirus had a opportunity at this or that event to enter the community event at some point, and when it entered the community, it spread very quickly due to perhaps sociability. This is our answer for now, and we hope to have greater insights in the future. Thank you. Thanks,
Daniel. And we'll look forward to hearing more on that, because I think that's something that a lot of people have been very vexed by. So let's turn to, there's a very specific question for Moishe about burial boards. So Moishe, have you been communicating and working with the other Jewish burial boards from around the country? That's a question that's coming from the audience, and thank you for that question.
Yes, absolutely. As I mentioned earlier, I'm just one of a very large team of volunteers here in Manchester. But there are Jewish people all over the Northwest to start with, and many of our volunteers go continuously to outlying communities who will not do the Tahara process now during COVID, whether the person passed away from COVID or even if not, they just don't have the teams to be able to go out to do the Tahara process. Because it means people gathering together in close proximity, putting on PPE and so on. So our volunteers will go out continuously out to Southport, Liverpool, Blackpool, Hull. We've been all over the place, Lancaster, wherever it is, dealing with those burial societies, bringing the deceased over to Manchester for the purification process, and then taking them back to their local burial grounds. In addition, we're continuously speaking with the burial societies in London. Just for the latest updates continuously. I mean, this was at the beginning of the pandemic, with Public Health England publishing continuous different papers on what we can and can't do and what they were doing. That was mainly Professor Katz updating us continuously with some Zoom meetings with other burial boards. In addition to that, many people who passed away here in Manchester during the pandemic wanted to be buried in Israel. And for that, we had to send them down to London and liaise with burial boards in London for them to take over once we've got the paperwork done from here. Likewise, many people who are in care homes up in Manchester have come here to retire nearer to their children, but their burial place is back down in London. Many people were, either brought up to Manchester for burial, including my 95-year-old grandmother who passed away a couple of weeks ago. So yes, we're liaising continuously with burial boards the whole time. We've had some of our volunteers here in Manchester have gone down to Bournemouth to bring people back here for burial. So yeah, we're all working together.
That's good to hear, but we're sorry to hear about the loss of your dear grandmother.
Thank you.
And Charlotte, questions just come in very much. I think this one's very much for you. Why are there so many variants, and should we be worried about them?
So I'm not a virologist, but I can give you my background of what I'm aware of, and it's not a surprise that we've got variants. So there's the main sort of types of organisms that can infect us. The three main organisms are bacteria, viruses, and fungi. We know with viruses that they are made either of the genetic code DNA or RNA, and they change very quickly. So they multiply really quickly, and then they change. They can have small little changes or mutations in just some of the DNA base pairs within them that can make them different. So we know that from our experience from other viruses. So we know viruses, and the commonest one that you'll know about is flu. So flu vaccine, so those of you who are over 65 would have been offered a pneumonia vaccine. So that's for a bacteria that once you have that over 65, you're covered, you don't need to have it again. But with flu vaccine, you'll be called by your GP year after year after year. And why is that? That's because the flu virus changes as time goes on, and from year to year is slightly different. So although if you have last year's flu vaccine this year, it won't be completely ineffective, but it will be less effective, because the work that's done by the scientific community is to try to predict what the changes will be in the virus and try to tailor the vaccine appropriately. So we're used to doing that. We've got a long history of doing that with flu. So it isn't a surprise that coronavirus is changing. So the first vaccines that have been done are the genomic sequencing that was done right at the beginning when coronavirus was first discovered. And we're not surprised that's changed. So the commonest ones around at the moment that you'll know of is this Kent variant and also the South African variant. Luckily, most of it in the UK at the moment is the Kent variant. And we know that the two vaccines that we're using at the moment, the Pfizer and the AstraZeneca, are effective against the Kent variant. We're getting more information about the South African variant, and time will tell about that. But what you'll have heard over the weekend is Nadeem Zahawi, the vaccine minister, saying that what's likely to happen is that we're going to need a booster each year. And that's partly because our antibody levels might wane, so we won't need to boost them up again, but also because the nature of the virus is going to be different, and it will have mutated a bit over the year and changed. So we're lucky that we've got incredible genomic laboratories that sequence, and UK has one of the best set of laboratories doing that in the world. So we're lucky we've got access to that to help then give the genetic material to the people who are producing the vaccines. And it's not a hugely complex process to actually, once you've established a safe vaccine, just to tweak it a bit. So it doesn't mean to say that this vaccine isn't going to be effective for future variants, but it will probably be a bit less effective. So what we want to do is get it as effective as possible. And we were absolutely staggered that when the vaccine information came out, that we're saying that we're getting sort of 70, 80, 90% effectiveness. Reality is for flu vaccine, it's about 50% effective each year. And we still think that there's a huge value in having that. But the coronavirus vaccines are even more effective. And we were staggered at how phenomenally successful they were, and their efficacy is so huge. So because viruses change, that's not a surprise for us. We just have to work and change in that, and probably we will be having top-ups each year, and that will be to target the different variations that we have.
Thanks, Charlotte. And I'm reminded of actually David's earlier comments about how long, of course, the world waited for a vaccination to do with polio, and just how quickly we're seeing this vaccine available now for COVID. Shows, I think, how things obviously have changed. And with that, I'd like to come to David to ask the next question from the audience, which is, do you know, David, how the track and trace system has been used by the Jewish community?
I think that what I've said before, the track and trace system just is an example. Unfortunately, put it bluntly, it hasn't worked in the UK. The system has not worked in the UK. And one of the long, hard questions that are going to have to be looked at as we come out of this period is why it hasn't worked. In the part of but we have learned lessons from the Israeli system, because there it's the engagement of the local communities, the local nurses, and the local Kupat Cholim clinics in Israel that have really been the focus of the vaccination strategy and have been also the focus of the test and track system. And it's one of the unfortunate features of the British society is that we have run down those kinds of services. And to my mind, it hasn't worked in the wider society. And because we are part of the wider society, particularly when we come into contact as we walk down streets, as we go into shops that we have to, as we go into parks and encounter people, we encounter people all the time. And if it's not working for one part of the community, it's not going to work for another part. If I might just add one point, Moishe has mentioned work that I've done with the Chevra Kadisha. I just want to use that as also an illustrative example, because I didn't do any great work at the moment. But many, many years ago, the Chevra Kadisha approached me and some colleagues of mine, virologists and microbiologists, and we drew up what one needs to do in handling bodies in times of serious infectious diseases, and to err on the side of caution in having protective clothing and protective equipment and in cleaning. And really what I've been doing now is reiterating those precautions. We advised the Jewish community at the time of HIV when it first started, at the time of the BSE, how to handle infectious conditions. And it's those precautions that we've been giving to the Chevra this time, slightly modified for the circumstances. So again, that's a question of the preparedness and the infrastructure, as in test and track, that needs to be available. And we need to think in advance of this and invest in this in advance.
Sure, that's very true, David. Thank you for that. I'd like to turn now to the report that came out recently, which indicated that 65% of the Haredi community had COVID during the first wave. And the question for the audience asks any of our panelists if they can tell us more about this. So for this one, I'm going to be turning to Daniel. Thank you.
Thank you. Thank you, Gillian. Of course, this is the report, very fresh paper, academic paper that has been authored by a team of researchers from the London School of Hygiene and Tropical Medicine. It came out, it's very fresh, hasn't been peer reviewed. And it indicated that the levels of having an infection, having COVID at some point since the beginning of the pandemic, indeed, these levels are very high among the strictly Orthodox, as high as 65%, and that should be seen in comparison to the national figure, which is about 7%, and the London figure, which is about 11% or so. So incredibly high indeed. And of course, the question that everyone asks, well, first of all, is that true? I think I don't have, having reviewed the paper, I don't have any particular fundamental doubts as to the veracity of the finding itself. And the second question, of course, perhaps equally important, why is that so? And here I would like to reach to my previous comment and say that we, in view of the work that we did in JPR and other work that is being done on the why people contract COVID and how they contract it, again, our hypothesis here is sociability of this community, which is over and above what happens in the rest of the Jewish community. And I will give a few statistics to illustrate that. The average household size in Britain is just above 2, or 2.3. The average household size in the mainstream Jewish community is about that as well. The average household size is among the strictly Orthodox is about 5. And when I say 5, it describes people at different stages of their life course. So if we remove from that 5 the margins of people who haven't started the family and people who already, whose children left the household, we are basically remaining with a very large proportion of people in this community who have very large households, as many as 7, 9, 12 people. The contact in this society is very, very intense, the contact of people with each other. And it is natural at such large household size. That's over and above the ritual life, which is also intense, the celebrations, which also happen. So it should be expected in a way, given the sociability, patterns of sociability, but also household size of this particular community. The last point that I would like to really drive home is this. When I spoke to the researchers who authored this paper, it was clear to me that they have been approached for comment more than once. And one of the comments that they receive, and that's in the air, is there a non-compliance with lockdown regulations in this community that's rampant, and that actually this is what actually impacted this particular figure. And in response to that, I would like to bring a particular exhibit which I prepared. If slide number 1 can be shown now, please. Thank you very much. This is an exhibit from the paper, which I'm sharing now. And what I would like you to do, anyone who watches, not to focus on every single detail and what it is exactly, but look at it like you look at the picture of a person, to just get the general shape of what you see in front of you. So on the left, there is a panel that documents that the people were asked in the survey, on the basis of which this paper was drafted, if they experienced some sort of COVID-like disease, illnesses, and when they experienced that. And you see a timeline, and you see 2 very strong peaks. I will call them humps as well. One happens approximately in April. Then there is a summer when nobody reported this set of symptoms. And then autumn kicks in and there is another hump. So it looks like a 2-humped camel almost. And I would like this picture to stay with you, because the expression blindingly obvious has been invented for this picture. What's blindingly obvious in this picture is that there was a very strong peak of disease in the spring that ended very, very sharply. And that can only happen if majority of population change their behavior. And this is what happened to strictly Orthodox. You can see it with your own eyes, that this population significantly changed their behavior, and this is what created this tremendous depression in the middle, in the summer. And then, like in the rest of the population, the exposure to disease picked up in the autumn. I would like now to show another graph. This is slide number 2, that shows a very similar picture. Now, at the top left, you see a 2-humped camel, which I wanted you to see. This is a Bactrian camel from Mongolian steppes. This is the general British population. The cases in the British population, as a whole, go up in the spring, and then they come to a very strong depression post-lockdown. It's related to the lockdown, and then they pick up in the autumn. The same happens below in London, although the second hump is not yet developed there, simply because the measure is slightly different. At the top left, you can see the 2-hump structure from Israel. That's exactly what's happening there. And at the bottom left, at the top right, you can see Israel, and at the bottom right, you can see strictly Orthodox population in the city of Bnei Brak in Israel, with this tremendous hump on the left, and then strong depression, which again really, as they say in Hebrew, tells you as 1,000 witnesses that there has been large-scale impact of lockdown on this population. This is completely unambiguous. Thank you. I will finish my remarks on this note.
Thanks very much, Daniel. And the camel will remain with us as a vision. Thank you. And I'd like to ask a question which actually builds on an earlier one, which is this one. COVID has led to the world becoming much more tech savvy in a very short space of time. Do you think that any of the technological innovations that we've seen, such as Zoom, GP appointments, registering deaths digitally, etc., will continue once life returns to normal? So I'm going to start first of all with Moishe for his area of expertise here.
Well, I certainly hope so. Having dealt with for years and years with bereaved families, the last thing anyone who's just suffered a bereavement wants to do is chase around the hospital for the doctor, wait around by the bereavement office, or call up their GP to say that my loved one has passed away at home, but I need a death certificate written, and the doctor's dealing with their own patients, and you can wait and wait and wait, and it gets extremely stressful. The next stage is once you have the certificate, you then have to get into town, your local registry office. If it's Manchester, you've got to find parking. Then you go upstairs, you've got to wait. You've got to tell them it's a faith death. They'll give you an appointment when they can, just to give you the green that you can have the burial that day. The stress is incredible, and it's just the last thing anyone wants to do. I'm hoping that I've spoken to quite a number of coroners and senior registrars, and we're hoping that this is going to be the way forward, where doctors, hospitals will just write the medical certificates, and everything will be done digitally. The papers will come back digitally. Registration will continue on the phone. It's definitely going to continue for the next couple of years, so I understand. And no one has to go running around doing anything. They can just prepare themselves for the funeral, or grieve without having to do all this, have this stress running around. So for sure, I hope this part is something that we've learned that works and works very well, and we hope it stays.
That's interesting to hear. You're right about it's so important to remove the possibilities of distress and difficulty at what is already an incredibly difficult time.
Yeah,
Charlotte, your thoughts on this about us becoming more tech savvy? What's gonna last the course?
So I think this definitely will. I think it's about proportions. I mean, in my practice, I was trying to encourage our practice to move to a digital way of trying to communicate with our patients, aware that actually those who knew how to work the system, so those, we used to have appointments on the phone, we used to have some booking by web, and some people clicked that actually if you went on the website at midnight, 1 minute past, loads of appointments got released, and so went on. So actually the people who were able to access the appointments the most weren't always the people who needed them the most. So no system is for everyone, and I think the difficulty with the introduction of the electronic systems and going to a virtual system in COVID was, to start with, we were encouraged to see virtually nobody because there was so much COVID around, it wasn't safe, and there was a lot of transmission of COVID in healthcare settings. And I used to speak to people on the phone, they said, please, can I come in? And I said, of course, I'm sitting here, I want to see patients. That's, any GP has trained to see patients. It's not actually particularly enjoyable sitting all day on the phone. We want to see people face to face, but actually if we give you COVID in the process, we haven't really done you any favours. So the problem was the pendulum swung very, very quickly. It swung overnight, and we went to this virtual model overnight, and nothing is absolute. And with time now, what we're doing is we are bringing more people in as appropriate. So on a typical surgery, most of the people I will see virtually, but actually I'll bring kind of 3 or 4 people in per session, so per half day. And that seems to work well, and people seem to respond to that. Ask anybody, can you get through easily to your GP on the phone? And they'll say no. The aim is for those who can use the virtual system and communicate digitally with the GP, that will then spare the phones for those who need it. So we know no one size will fit all. And really, we want the phones to be free for those who can't work, who either don't have access to internet or digital, or who for English is not a first language and struggle with it. We want the phones for people who really need them. And the aim is, often I have a discussion with patients and they say, oh no, I really don't want to do it, and I encourage them, and then they say, it was great, I could message you at 2 o'clock in the morning and then you responded to me the next day. The system is very much better, and I really don't want to go back to the old system where you'd call, you'd get an appointment for something often that could have been dealt with virtually, and it would take 2 or 3 weeks to get an appointment, which was certainly not good for your own health and not good for the health of the general population. So lots of fantastic stuff that's happened with it. I don't think we'll go backwards, but I think there'll be more of a balance, and I think that will be easier for people, and people will get used to it as well.
Thanks, Charlotte. And David, what's your view on what we'll take with us?
Well, I just wanted to add on one small point, because I think Charlotte's points were all excellent. The one small point is that, of course, this is an entirely new, the RNA vaccines are an entirely new venture, and they're going to have an impact on the way we handle infectious diseases, and we're able to handle infectious diseases in the future. And I think in 20 years' time or 30 years' time, when the next pandemic comes along, we'll look back on the advances that have been made now in that specific area as being very revolutionary.
I'm sure we will. So, as ever, I don't know where the time has gone, but it has gone. And we're just drawing to a close now. And I've just got one final question for some of our panel, which is, what is the main lesson that you are taking from this pandemic? So, I'm going to come first to Charlotte on this.
Thanks, Gillian. I think out of crisis comes opportunity. So I think this is terrible. The legacy of COVID is terrible. But with everything that's bad, there is also good, and that will carry us forward. And the good that's been seen, as we described in the community response, and particularly the Jewish community response to it, the good that's happened in the evolution of technology where there's been need is absolutely fantastic. So I think it's just that really, that age-old lesson that out of crisis has come opportunity. And I think in that sense of community, that kindness to each other, a respectful way of communicating, supporting those who need it, that will really, the progress we've made in that is huge, and actually the legacy will live on way beyond this COVID pandemic.
Thank you, Charlotte. Daniel, briefly, what's the main lesson you're taking from this pandemic?
I think it's a lesson of regarding preparedness. I mean, when the pandemic started, the first question, the second question, third and fourth and fifth that we will ask, the more or less questions that people asked here. Why are Jews dying disproportionately? Why are they dying disproportionately? And this is a resounding question, really recurring. In order to answer that early in the course of the pandemic, we need data. And in order to get data, we need ongoing research pre-pandemic. This question should be 90% of this should be answered in order to give real answer in time. And to do that, to collect the data, we need funding. It's very, very, well, it's never easy. Getting funding is never easy for all Jewish charities, without an exception. And for us, for the researchers, it's sometimes difficult to make this particular case, you know. It's not so difficult to explain to people why they need things like childhood illnesses or elderly care require investment, but it's difficult to explain how research is relevant in the immediate term. And this is my plea really today. In order to answer these questions about the pandemic, we need to do all our research pre-pandemic. We need to collect data on this, and we need funding for these particular, for research purposes. I think now we arrive to a point where I can say research is a matter of life and death. It's not a luxury.
Thank you very much for that final thought, Daniel. Moishe, what's the main lesson you're taking from the pandemic?
The incredible amount of chesed. I'm not sure how to translate the word chesed, although I hope everyone understands what it means. I don't think there is an English word for it. The incredible amount of chesed that is going on in the Jewish communities, across the UK is just staggering. Just from a friend of mine who actually passed away at the age of 60 with COVID. He's actually one of the team, one of our colleagues on the Chevra Kadisha. I mean, his wife, has got small kids at home, and she alone has set up an organization to help other widows. That's just one of them. But the chesed that Hatzalah have done here in Manchester, in London, all over the place, the amount of people they are looking after at home and have stopped people going into hospitals and taken the burden off the NHS is absolutely incredible. My mother was in hospital for 2 weeks with COVID. When the hospital released her, they released her to the care of Hatzalah, and Hatzalah brought their own ambulance to take her home. And there's Ezra Marapa, who have got hospital equipment, oxygen tanks, which they're delivering to people's homes. There are food banks that are delivering here in Manchester. I know for, taking out food to people who are too scared to go out shopping. And so it goes on. It's just incredible. The lists that are published weekly of the chesed organizations that are going on in the Jewish community since COVID started is just absolutely staggering. And it's heartwarming to see.
Thank you, Moishe. And the last word goes to David. Your main lesson.
Thank you. The main lesson to me is humility. I think we were very, very arrogant about how life could carry on before, and this is a lesson. And the humility carries with it the responsibility. For those I think I'm the oldest person on this panel, that we have a responsibility to our children and grandchildren to make sure that they don't suffer from the same kinds of problems that we've had to suffer now.
That's a very wise final set of words for us, David. Thank you. And thank you to you all. And my thanks in closing, what has been absolutely fascinating and very rich evening, is I want to thank all of the members of our virtual audience for watching and for submitting such relevant questions. And on behalf of us all, I want to say a huge thank you to our panelists, Dr. Daniel Staetsky, Moishe Sinitsky, Professor David Katz, and Dr. Charlotte Benjamin. We so appreciate each one of you for what you've done this evening in sharing your unique insights and expertise in what is undoubtedly uncharted territory that we're all living through. And most importantly, I want to thank you again and your teams for all of the important work that you are doing at this time. To anyone watching, if you'd like to keep up to date and support the vital work of the Board of Deputies, then please go onto our website, please donate, and please sign up to receive our community briefing. So all it leaves now is for me to wish everybody all good health and all strength during this challenging time. Thank you. Enjoy the rest of your evening.